Organic brain syndromes by Jones HMMBADMS. These are mental illnesses or conditions that result from diffuse impairment of brain tissue function from whatever cause. These syndromes or cluster of diseases are subdivided into psychotic and non-psychotic depending on the severity of the functional impairment of the brain. A patient who cannot meet the ordinary demands of life is considered psychotic. Normally, acute brain disorders are reversible, whereas chronic brain disorders tend to have permanent or irreversible impairment. Classifications. Patients with similar clinical manifestations may be classified differently depending on the examiner's discipline, training, and background. When a physician is confronted with a patient who has a mental disturbance, may first attempt to decide whether the disturbance represents an organic impairment of brain function or a functional disturbance or both. Once he or she decides that the patient is indeed suffering from an organic disturbance, he may properly classify the disorders as some form of encephalopathy. Only when satisfied that a focal disturbance of brain tissue function is absent can one properly use the term organic brain syndrome. Therefore, organic brain syndromes can be classified as follows. 1. Acute brain syndrome. This has four primary characteristics such as I. The onset is sudden with the rapid development of impairment of orientation, memory, intellectual function, judgment and affect or mood. I. Delirium, stupor or coma may be present at times associated with the release of the underlying psychotic and neurotic reactions. E. The syndrome is caused temporarily, reversible, diffuse disturbance of brain function. If the clinical course, although usually brief, may persist for a month or longer, but it always ends with some resolutions of the organic symptoms. 2. A chronic brain syndrome. This has also four primary characteristics, namely I. Onset is often but not always slow and insidious, taking several weeks or more and progressively impairing brain tissue function. I. The clinical expression is often described as a dementia, but sometimes delirium, stupor and coma supervene, especially in advanced states. As with acute brain syndromes, the symptoms of organic and functional impairment of brain function may coexist. E. The syndrome is caused by an irreversible, permanent diffuse alteration of the brain function. If the clinical course usually progresses over months or years, and the syndrome may end in death. Although the responsible agent is identified and removed, some permanent alterations in brain function remains. The varieties of organic brain syndromes, OBS, are A. Delirium. This is a mental state in which there is impairment of consciousness, resulting in reduced levels of alertness, attention, and perception of the environment. Etiology. Drugs such as digoxin, diuretics, alcoholic intoxication and withdrawal, steroids, etc. Infections, cerebral malaria, meningitis, HIV/AIDS, PUD, UTI, septicemia, etc. Diseases, diabetes mellitus, renal syndromes, rheumatic heart disease, hepatic, etc. Hypohyperglycemia. Neurological diseases, epileptic seizures, head injury, tumors, cerebral hemorrhage. Old age. Constipation. Dehydration. Pain. Clinical features. Disturbed consciousness manifested by confusion, drowsiness, decreased awareness of the surrounding, disorientation in time, person and place and distractibility. Hallucinations visual, auditory, olfactory, and tactile, gustatory. Dementia. This is an irreversible organic brain syndrome which is a generalized impairment of intellectual ability, memory and personality with no impairment of consciousness caused by brain disease or injury, and it can be acquired as distinct from AMENTIA, mental retardation, which is present from birth. Onset. The onset and course is slow, insidious, progressive and terminal. It takes 8-10 years from the time the disease begins to the time of death. Dementia comes in phases or stages, namely Phase Stage 1. Common features in this phase. The client in this phase would show short-term memory problems, difficult in paying attention and concentration, becomes ambivalent, uncertain in actions or thinking, difficulties in making decisions, loses interest in the environment, events and situations, apathetic. Demonstrates deterioration in social activities. Covers up errors. Phase Stage 2. Common features in this phase. Demonstration of obvious memory loss deficit. Hesitation with verbal initiation or response. Disorientation to time, place and person. Complains of neglect. Forgets appointments, routines and events. Accuses others of stealing. Hides his or her property, but forgets location, place. Phase Stage 3. Common features in this phase. Severe memory loss. Disorientation to date, person, time and place. Displaying motor deterioration. Immodest behavior. Inability to recognize oneself in the mirror. Needing help on all daily activities. Unsteady gait. Inability to write or read. Phase Stage 4, terminal stage. Common features in this phase. Global memory loss. Psychotic behavior, violence, aggression, irritability, crying. Anyhow, etc. Ataxia. Inability to recognize anyone. Inability to eat or feed oneself, but fed directly or through tube. Incontinence with urine or stool. Resistance to bathing. Marked weight loss. Susceptibility to infections. Death. Etiology. A. Degenerative brain cells. This is common in senile dementia, Alzheimer's disease, Pick's disease, Parkinson's disease, multisclerosis, hydrocephalus, etc. B. Intracranial space-occupying lesion, such as tumors, subdural hematoma. C. Trauma. Severe single head injury. Repeated head injury. Concussion such as boxers. D. Infections. Encephalitis of any cause. Neurosyphilis, GPI. Cerebral sarcoidosis. E. Vascular diseases. Multi-infarct dementia. Occlusions of the carotid artery. Cranial arteritis. F. Metabolic disorders. Sustained uremia. Liver failure due to cirrhosis. Renal dialysis. Remote effects of carcinoma or lymphoma. Hyperhypothyroidism. G. Toxic substances. Alcohol. Poison with heavy metals such as lead, arsenic, thallium. Cocaine. DAGA. H. Anoxia. Anemia. Post-anesthesia. Carbon monoxide. Cardiac arrest. Chronic respiratory failure. I. Avitaminosis. Prolonged lack of vitamin B12. Folic acid. Thiamine. General signs and symptoms. Incontinence. Restlessness. Aggression. Slow thinking. Loss of pattern of thought. Loss of feelings. Inactivity. Incoherent speech. Agitation. Self-hygiene neglect. Disorganized behavior. Investigations. CT scan. Renal function test. FBC, ESR. Reactive protein. Abnormalities will suggest infections or other problems that cause mental deterioration or confusion. Assessment of cognition, interview patient, test memory, test attention, language skills and emotional test. Management. Nursing care-assessment. Establish cognitive status using standard measurement tools. Determine self-care abilities. Assess threats to physical safety, e.g. wandering, poor reality testing. Assess affect and emotional responsiveness. Assess ability and level of support available to caregiver. Nursing interventions. Speak slowly. Use short, simple words and phrases. Introduce yourself. Address the patient by name. Focus on one piece of information. Review what has been discussed with the patient. Keep the patient in a well-lit place. Keep clocks, calendars and familiar personal effects in the patient's clear view. Identify and acknowledge patient's feelings if he or she becomes verbally aggressive. If patient becomes aggressive, shift the topic to a safer and more familiar one. Reinforce reality and acknowledge feelings of the patient if he or she becomes delusional. Encourage decision-making in a patient regarding ADLs as much as possible. Keep patient in a well-protected environment to prevent injuries as he or she wanders about. Label patient's clothes with the patient's name, address and telephone number. Encourage physical activity during the daytime. Install alarm and sensory devices on the doors of such patients. Provide magazines with pictures because reading and language diminish. Encourage patient to participate in simple, familiar group activities such as singing, reminiscing, doing puzzles and painting. Respond to the patient calmly. Do not raise your voice. Remove objects that might be used to harm oneself or others. Identify stressors that increase agitation. Distract patient when upsetting situation develops. Monitor food and fluid intake. Provide good food for patients, some of which must be portable. Sit with patient during meals and assist by feeding, if not able to eat. Chemotherapy. Give anticholinesterase which slow the progression of dementia by increasing the relative amount of acetylcholine. The drugs given are donepezil, Aricept, galatagument, Reminil, rivastigumab, Exelon, Tacrine, Conex, haloperidol. Complications: fractures, injuries when patient falls, aggression or violence, wandering about leading to missing or being killed. Caregivers, especially loved ones, may suffer from depression. Patient neglect or abuse due caregiver stress and burden.